the Fibroid Foundation welcomes you to Fibroid Summit 2024.
How's everyone? It's so good to see you all. This is our first in-person Fibroid Summit. This is the 4th annual, but the first one we've done in person, and it's so meaningful to be able to see all of you and be able to just converse and hear your stories. I always learn so much and take away so much for where we need to focus our efforts. So thank you for taking time out of your Saturday to be here. I'm Sateria Venable, founder and CEO of the Fibroid Summit and Foundation. This program was designed to showcase emerging science in fibroids and in menstrual health, because we've learned over our 11 years that it's not just fibroids, it's the stigma around menstruation in general, which even bridges into menopause, that needs our attention and our understanding and our work to really try to dissolve those stigmas. And Summit is unique because although it's attended by clinicians and patients, the Q&A session is intended to provide patient insights directly to the research and clinical community. So during the Q&A sessions following each presentation, we look forward to your questions and comments. Data shows that 1 in 3 women will be diagnosed with fibroids over the course of their lives. And arriving at a diagnosis can be a winding road filled with misinformation and limited treatment options. I have had 4 fibroid surgeries, which led to the creation of this organization. And I was just a frustrated patient, not really knowing where to go for care. And when I found out about the statistics, I was just floored, because I thought that I was suffering through the symptoms alone. And then when I hit menopause, I thought, here we go again, like there's no information. So we incorporated that into our programming. So we're here today to share important information with you to help you to have proactive conversations with your health care provider regarding your care and healing, but family members as well, because the way we care for ourselves is often information that's handed down generationally. And so we're looking to change a lot of that. We did a church event in Bowie 2 weeks ago, and there were 2 themes that we heard a lot. One was suffering, the thought of suffering through the symptoms, which I believe is generational. That was my thought. And the other one was just have a hysterectomy, where sometimes because of health disparities, that's the only option that's offered, particularly to women of color. And research has now shown us, Mayo Clinic has done research that shows that over 80% of fibroids can be addressed without a hysterectomy. And that is often news to women and menstruators who have fibroids. And so we really want to make those minimally invasive treatment options available to you through our website and through events like today and the wonderful speakers that we have joining us, because the treatment options and the research that goes into developing those treatment options is vital for improving understanding, diagnosis, treatment, and overall management of fibroids. And ultimately, it will enhance your quality of life. So we're committed to elevating that research in a way that's meaningful. I would like to acknowledge our sponsor, always, a period care brand by Procter & Gamble. Their support has been instrumental in making this summit possible. And we are grateful for their commitment to menstrual health. So please join me in giving them a warm round of applause. So our first speaker today is Samira Rafaela. Samira was a member of the European Parliament from 2019 to 2024. And this year she joined the Global Labor Institute as a visiting fellow of the Cornell University ILR School. Samira has graciously leveraged her platform to support women's rights and address health inequities. And I am so grateful that she traveled to be with us today. So please join me in welcoming Samira Rafaela to the podium.
I always need to adjust it because even when I put on heels, it's not enough. Thank you, Sateria, for the invitation. I'm trying to make sure it's stable. Yeah. Thank you, Sateria, for the invitation and for your leadership in raising awareness about such an important topic, an often overlooked issue. Fibroids are an issue that to many people is underestimated and it's dismissed by many people, and yet they have a profound impact on women's lives, of countless women in the world. And I'm grateful that we have the opportunity also today to share our journeys, experiences, because I truly believe that is very important for making sure that the topic stays on the agenda. And when it comes to my own journey, I'm standing here now, fit, energized again. But 2 months ago, I was confronted with this issue head on. So I had my own surgery and to remove a few fibroids. And I went into the operation expecting them to remove just one large one. And when I woke up, they told me they had to remove several ones. So that was a surprise, but also a good surprise. Well, okay, well, let's get rid of them then. But even now, I'm not completely free of fibroids still, though they're that small that they say, well, we'll just keep monitoring it and hopefully you don't need an intervention soon. But I do realize that keeps you busy in the back of your mind, right? It is a certain mental pressure that you continue to live with. And I think also when it comes to the mental impact of fibroids, we should not underestimate that. Research and surveys have shown that, if I'm correct, 70% of the women with fibroids have complaints, mental complaints, because it is stressful. You are thinking in the back of your head, like, okay, what is it going to do? Is it going to grow fast, etc. So the mental care when it comes to fibroids is extremely important. And it wasn't the most intensive surgery for me, but it wasn't minor either. It's an experience that I wouldn't wish upon anyone. And the aftermath makes you realize that you are very vulnerable. So I was used to being up and running as a member of European Parliament 24/7. And I haven't had the experience 5 years long to just lay down and do nothing. I couldn't do nothing for 2 weeks. So accepting that reality was really harsh. But that's what I'm saying. These interventions are not a joke. And it is indeed very important that there is a variety, right? A diversity when it comes to treatment, and that we don't need to undergo the most extensive one right away, if there are also other possibilities. So after this experience, I began to ask myself, how could I prevent the growth of my own fibroids? Is that even possible? Or at least slow it down? So I quickly realized how difficult it is to find comprehensive, reliable information on this topic. And the journey to understand fibroids is not easy for women, but I kept digging. And thanks to a fellow fibroid warrior, Alexandra Atalita, we have both roots in Curaçao, here in the Caribbean, close to DC, I discovered the Fibroid Foundation. And when I stumbled upon the Fibroid Foundation's Instagram page, it was like a lifeline. The tips, the stories, and the shared experiences made me feel seen, heard, and supported in a way I hadn't felt before. And to the Fibroid Foundation, thank you for being such an invaluable resource. And this lack of information on fibroids sparked a personal mission in me, a mission to talk openly about our bodies and the health challenges that so many women face in silence. So this journey led me to the launch of my own initiative, Let's Talk About Our Bodies. I came across my first fibroid by chance, so during a routine checkup for an unrelated issue, and they were like, hey, did you know you have a fibroid? I was like, what? And suddenly it all clicked. So I started remembering stories of women in my own family who had comparable health issues. And I began to realize that this was something much bigger than me. So I turned to my friends, to women in my environment, and I was shocked about the lack of awareness. Why don't we talk about this? Why don't we talk about our own bodies? So Let's Talk About Our Bodies was born, and through this initiative I've organized expert panels bringing together major organizations across Europe to discuss women's health issues, particularly those tied to reproductive health. And I jokingly always say to them, well, everything that is connected to the uterus is up for discussion. So let's talk about the uterus in general. And I learned quickly that even in medical education, certain health issues are under-discussed, especially when it comes to the intersectional aspects of women's health. For example, Black women, we know the statistics, significantly more chance to get fibroids. And recently I had the privilege of connecting with doctors at the University of Chicago and professors, and their research has provided groundbreaking insights, I can tell, because I didn't know about it, even though I did a lot of research already. And one finding in particular resonated deeply, a deficiency in vitamin D as a major factor in the development of fibroids. And I was like, so who's the most at risk here? People of color, women of color in general, but how can it be that such a simple yet life-changing piece of information isn't widely known? Why don't we just all know, just make sure that your vitamin D is good for women in general, because it can prevent you of having fibroids. So I want to make also a call to action. I do that in general when I speak about the topic. We need more research into the relationship between diet and fibroids. Anti-inflammatory foods, in particular, are something I've been experimenting with, and I've already seen positive changes in my life. I'm not a medical expert, I do need to say that. I am not the medical expert, I am not the doctor, I am not the professor, but I'm a lived expert. And for years, I used to miss work every month due to menstrual pain. So since I adopted this diet, I haven't needed painkillers now for 4 months. And I even had a month with 0 pain. And I couldn't believe it. I was flabbergasted. I was like, where's the pain? And it wasn't there. So imagine that a simple dietary change made such a profound impact on my life. So why aren't we being informed about the role of nutrition in managing menstruation and even fibroids? So this is a type of knowledge that can truly transform women's life if we put more research into that. So I am incredibly grateful for the work being done by the University of Chicago and others in this field, because it shows just how powerful information and research can be. And it's a reminder of why we need more conversations, more exchange, more knowledge sharing. And in Europe, I've been working with the European Public Health Alliance and other organizations to put women's health firmly on the agenda. So this summer, I presented the Let's Talk About Our Bodies manifesto to the EU Commissioner of Equality, and in partnership with these organizations, and the event was even hosted by UN Women in Brussels. And at that event, we presented a strategy and laid out 4 concrete priorities for advancing women's health. So first of all, close the gap in women's health research and innovation, secure bodily autonomy and the right to health for all women. 3, nurture a health workforce that represents and serves everyone. And 4, lead and collaborate by example. So I'm proud to say that we've already seen results in the Dutch Parliament. A resolution was introduced based on my manifesto, calling for a national strategy and increased funding for research. So I'm committed to pushing forward with this mission across Europe and building partnerships here in the US, because I believe that only by working together we can make real lasting progress. When it comes to fibroids, like I said, it impacts so many lives of women, and too often they're overlooked, dismissed, and yet they profoundly affect the health, well-being, and daily lives of millions of women around the world. So today I also want to highlight the real impact of fibroids, why it's critical to increase the support and understanding on how we can make a difference in the lives of women affected by the condition. In fact, research shows that up to 70 to 80% of women will develop fibroids at some point in their lives, with women of African descent being at a significantly higher risk of developing them earlier and experiencing more symptoms. And by the age of 35, I'm 35 now, so yeah, the statistics were pretty correct. Approximately 60% of black women have fibroids, compared to 40% of white women. And by the age of 50, that number rises to over 80% for black women. That's like almost all black women. So living with fibroids can be a struggle. And for women who experience heavy bleeding, meaning menstrual periods can be a logistical nightmare. And some women find themselves planning their lives around their cycles, knowing they may have days where it's almost impossible to leave the house due to excessive bleeding and severe cramping. And this can impact the work, the social lives, and the mental health, as I mentioned before. Many women with fibroids feel isolated and misunderstood, as few people truly understand the severity of their symptoms. And in some cases, the pain and discomfort can lead to missed work days, therefore also lost income and strained relationships. And I want to emphasize also the economic implications of fibroids and menstrual health in general. Because if we cannot effectively, sufficiently participate in the workforce, because we don't have sufficient solutions, or the workforce, people, organizations, the society don't understand us, what happens? We stay behind, right? Participation is more difficult. It can mean even something for your promotion, or the perceptions people have. Why is she always like, at least for 1 month? She's always sick. You know, the perception will always be, she's always sick. Like, why? What's wrong to her? So therefore, we need a workforce and a workplace where we can openly discuss this problem. It also has economic implications for women and the society. And the physical toll of fibroids is often matched by an emotional one. When it comes to immense stress, anxiety, and even depression. When it comes to infertility, right? Being insecure about whether you can conceive, whether you can become pregnant. And for the women who want to become a mother, that is very stressful if you have that wish. So even the journey to diagnosis can be lengthy and frustrating, as some healthcare providers dismiss symptoms or fail to offer meaningful solutions. And this is really where we need to start advocating for, making sure that also within the medical community there is enough knowledge, and that we take women serious, because women deserve better than this. Therefore, we need to prioritize education and awareness. Too many women don't even know what fibroids are until they are diagnosed. And this is, when I was thinking this through, I was like, okay, so for the medical community in general, lacking information, besides, you know, certain universities in the world and doctors and professors doing already a very good job. If women themselves don't even know about this problem, if they don't understand their own bodies, how can they then effectively advocate for their own health, right? So we're only in this phase of awareness and informing women, hey, it's not normal to have a lot of pain during your menstruation. A little bit, okay. But if you feel like dying, it's not normal. But how often are we being told, and it's also from generation to generation often, because we don't know better, oh, it's normal, just take a painkiller, just, you know, and we wouldn't do anything with it. So when it comes to educating women about it, that I believe is a very important task. That's of course, Sateria, what you are achieving with the Fibroid Foundation. And we need to make sure that we have it more on a collective level in society, right? Another critical area is research. I've mentioned that already. We need more research into effective, non-invasive treatment options. Currently, treatments around the world for fibroids are limited. And therefore, I also wish to have more research when it comes to the relationship between fibroids and diet and food. Because especially for women who are still hoping to have children, some of these options are far from ideal. So how can we put research into the question on how can we prevent women of having women, or how can we at least slow down the growth of these fibroids, right? When it comes to access to care, Too many women struggle to find affordable and compassionate healthcare that address their needs, and this is especially for women in marginalized communities. By working to make healthcare more inclusive and accessible, we can ensure that all women have the opportunity to get the help they need, and this might mean advocating for better insurance coverage for fibroid-related treatments or supporting clinics that specialize in women's reproductive health. So we need to break the stigma around reproductive health. Women's health issues are too often treated as a taboo, so a lot of shame comes with it. This is exactly why I called my initiative, Let's Talk About Our Bodies. Let's talk about it openly. I want women to just say, look, I'm going home today, I'm having my period, I'm just in a lot of pain, and you see me later. It needs to be normalized. It needs to be normalized for women to say, look, I'm out for 2 weeks. I have my surgery for my fibroids, right? It needs to be a normalized topic. When it comes to menopause, a lot of women feel discriminated. Nasty jokes, nasty comments being made about women in menopause. It's not safe for women to just talk about their uterus. So we also need to normalize that, even when we think it's a bit uncomfortable. And I started to do that because I was like, I also feel I have a responsibility, especially back then when I was a public person, to speak about it. And when I did that, I got loads of comments and responses. I mean, I did expect some, but this was really mind-blowing. So when we normalize conversations, we create an environment and a workplace where women feel comfortable seeking help, and it's also good for their careers, because at least they get the support and understanding. And it's not just women's issues. This is really a public health issue that affects families, workplaces, and communities. So the more we talk about them, the more we can drive change. And as a former legislator, I'm going to close. As a former legislator myself, I know how critical it is to have women, especially women of color, represented in politics and in decision-making spaces. The representation is vital for influencing policies on these deeply personal issues that affect our lives so profoundly. And yet, I worry about the future of political decision-making, especially if we lose ground in political representation. So that's why it's essential that we continue to advocate for our voices to be heard, and for political representation also, to keep this topic on the agenda, to reflect the diverse needs of our communities. And I hope that after the 5th of November, we can, well, you can, but trust me, the world is watching, breathe a little easier and continue this fight for change. I guess you know what I mean, and I guess you can also imagine in what team I am. So, in closing, let me say this: women's health is not a side issue. It is not a niche topic. It is a core component of public health, equality, and justice. And when we empower women to understand their bodies, to advocate for themselves, and to access the information and care they need, we empower entire communities. So let's keep talking, keep learning, keep pushing forward. I'm grateful for all the fibroids warriors, it's like a hashtag also on social media, that I got to meet. They endure pain, they adapt, they fight for the solutions, but they shouldn't do it alone. So women with fibroids, they shouldn't do it alone. It's up to all of us, friends, family, healthcare providers, policymakers, politicians, to step up and support them. So if I summarize, let's advocate for research, better treatment options, and more understanding, and make sure that women have the resources they need to manage this condition and live full, healthy lives. Thank you.
That's amazing. Thank you so much. Incredible. Wow, that was amazing. Thank you, Samira. I'll give you another hand. Thank you so much. Those words were incredibly powerful. And, the patient voice is really a game changer. So I really appreciate you leveraging your platform to be able to share your story with everyone, because I'm sure those those themes resonate with many of us, and the change that we want to see come forth. I think all of us here today are helping to make that a possibility. So again, thank you. Our next speaker is Dr. Ayman Al-Hendy. Dr. Al-Hendy is a highly skilled gynecologist who specializes in comprehensive women's health at the University of Chicago. He delivers expert care for complex gynecologic conditions, including uterine fibroids, infertility, and endometriosis. His expertise in minimally invasive gynecologic endoscopy allows Dr. Al-Hendy to diagnose and treat polyps, fibroids, bleeding disorders, and more with minimal or no scarring, faster recovery, and less pain. As a physician scientist, Dr. Al-Hendy is also dedicated to using basic and translational research to better understand the cause of gynecologic conditions and investigate new treatments that offer improved outcomes and overall quality of life. His work has been published in highly respected peer-reviewed journals, including Reproductive Sciences, Scientific Reports, the New England Journal of Medicine, and Cell Transplantation. When we visited Dr. Al-Hendy's lab in Chicago, we posted a photo of me looking through the microscope, and our community was like, "What do the cells look like? You didn't show the cells." So I called Dr. Al-Hendy back and asked him for an actual photo of fibroid cells, and we posted that, and it is still our #1 photo that we've ever posted, was the picture of the fibroid cells, and understandably so, because we want to know what's wreaking all of this havoc. And it piqued the interest of our entire community and provided a window into the molecular biology of fibroid cells that we as patients don't often see. So please join me in welcoming Dr. Al-Hendy to the podium.
Thank you, Sateria, for the kind introduction and for the invitation. When Sateria contacted me, there was, some of you might know, there was a major medical conference last week in Denver. It just ended on Thursday. So I said, wow, okay, it's going to be tight, but I would never miss this. I really love those events. Talk directly to the patient and their families, because in the context of a clinic, usually we are rushed in time, unfortunately. So thank you for the invitation. And also I'd like to thank Samira. I want to tell her I agree with you 100% on everything you said. That's rare. I usually don't agree with the previous speaker in medical conference. And I voted yesterday. I had a chance to go and vote early yesterday, so you can figure out also who I voted for. So today I want to talk about prevention of uterine fibroid, the emerging evidence, and really empowering you, the patient with fibroid and their families, with some of this evidence. We heard in Sateria introduction about treatment, and also Samira focus on treatment, and we'll talk a little bit about that, but I really want to excite you about the concept of prevention, and I'll tell you why this is so relevant for a disease like uterine fibroids. So these are my disclosures. Okay, so for this audience, clearly you know a lot about uterine fibroids. Personally, also in families, as we heard, fibroids unfortunately tend to run in families, and we'll talk about why. When something runs and a disease runs in families, it doesn't always mean genetics. It could mean other things. But again, to agree with Samira, 80% by the age of 50, 80% of black women or women of color would have fibroid. When you have a disease so common, it's not really just like a regular disease. This is an epidemic, and also it happens around the world. So it's really a pandemic. And as we all know from the experience during COVID, you cannot treat a pandemic. You have to prevent it. My wife is a COVID expert, and she tells me that the cost of treating one COVID patient can immunize about 4,000 patients to prevent the disease. So it's clearly more cost effective to prevent the disease, besides also avoiding the suffering and the struggle that the patient has with fibroid for many years, even after surgery, even after, kind of some treatment options, that the struggle doesn't really end. So I would really encourage all of us and those active in this area and the funding agencies and so on to start paying attention to the concept of prevention of fibroid, because this is a preventable disease, and I'll show you why I say that. Of course, for this audience, you know the symptoms of fibroid very well. Most common is heavy menstrual bleeding or abnormal menstrual bleeding, which, if uncorrected, leads to anemia. And again, I'm preaching to the choir here. When you have severe anemia, you're not yourself. You lack energy. You lack, you're fatigued. You're tired. Everything that Samira mentioned, and I'm sure all of you can relate. I have seen in my patient. I have patients sleep in the waiting area, waiting for their turn, and then they have a hemoglobin of 5. Normally, it should be 3 times more than that. It should be around 14, 15. They're just tired. And the University of Chicago, it's very hard to get into the University of Chicago. I had very bright black students in medical school, law school, just failing their exams and struggling with their studies. And again, we find their hemoglobin of 4, 5. And even if the hemoglobin is not bad, the low level of iron by itself, even if your hemoglobin is 12 or so, make sure you ask your healthcare provider to measure the iron. Because if your iron is low, even your hemoglobin is normal, cognitively, your mental function is not going to be the same. So that's very important based on some of our research and others as well. You have seen fibroids, I'm sure all of you, so they come in different sizes and shapes. Sometimes there are many fibroids in the same uterus. This is just briefly, because Sateria asked me to talk about the emerging evidence and so on. So this is really where we think how fibroid starts. Every young girl is supposed to be born with a normal, healthy myometrial stem cell. Then if you get a genetic hit, if you get a driver mutation, the most common one in fibroid is called MET12 mutation. It's just a different kind of type of mutation. Then this healthy cells become a tumor-forming cell, a tumor-forming stem cell. And then this cell just keep proliferating more and making a lot of cells. Also, fibroid cells are nasty to secrete those, what they call extracellular matrix. Things like collagen, like fibrous tissue, basically. Collagen, fibronectin, and that really makes the bulk of the tumor. So that's kind of the dogma based on our work and the work of many others where we think fibroid come from. But the other thing I want to emphasize on this slide, that we are way doing too many hysterectomies, especially in the US. This is the US data. We do about 6 hysterectomies per 1,000 reproductive age women. We are number 1 country among the developed countries in the number of hysterectomies. Way too many hysterectomies. Germany, which is the highest in Europe, is half of us. And Canada, and actually I did most of my clinical training in Canada, we do only 1 hysterectomy, around 1 hysterectomy per 1,000. So way less. So this is another trend that we probably need to think more about. So we published this article with some of my colleagues, Dr. Eva Stewart and Dr. Evan Myers, about the unmet need. This was a few years ago, and unfortunately many of these unmet needs are still there. We need better treatment option. We need non-hormonal treatment option. We need to find ways to avoid surgery, and we need to understand the disease better. And especially, the more we understand the disease, the more we get smarter about diagnosing it early, preventing it, or treating it with less invasive procedures. This is a case I've done a couple of years ago. And because Samira was surprised, they removed 7 fibroids. We removed about 80 fibroids from the same uterus, from this young black person. And the problem with that is they come back. The recurrence rate of fibroid is around 70%, especially in young black women. So just removing fibroid, unfortunately, is not the end of the story, because they tend to come back. And I know we all use the word come back, but they actually don't come back, but new ones appear. And I'll show you how this works in a second. So this is an article we published a couple of years ago, summarizing our work and the work of many others in the community, in the scientific community, about why fibroids are more common in black women or women of color. For all last century, the 20th century, and even early 21st century, everybody was documenting just the observation that fibroids are more common in black women. Just, epidemiology, but really nobody dug into the mechanism. I would say our group and many others in the last 15 years, we started to really dig into the mechanism. And as you would expect, there are multiple reasons why fibroids are more common in black. For example, exposure to environmental pollution. This EDC stands for endocrine disrupting chemicals. There are many examples of that, like phthalates. Some of these names you might have heard in the media and so on, phthalates and so on. But there are many others. Especially if a young black girl exposed to this very early in life, or even as a fetus in the uterus of her mom, if you get exposed to these things, then that actually causes a lot of inflammation in the wall of the uterus, in the myometrium. Increased body weight and obesity is also a risk factor. I'll come back to that. The altered bacteria, there's healthy bacteria in our gut and also in the uterus. If this bacteria is altered, it's called the microbiome. That also can lead to inflammation in the wall of the uterus. We heard about vitamin D deficiency a few minutes ago. We were first to report that something as simple as vitamin D deficiency can be a risk factor. And since then, many papers came to confirm that. And I'm actually just curious, maybe show of hands, those who know their serum vitamin D level. Just raise your hand. I'm impressed because I literally ask all my patients, and they have seen multiple providers, and nobody measure even vitamin D. And not even aside from the issue of the fibroid. If you look at the Endocrine Society, which is our kind of prestigious society responsible for hormones and so on, it's recommended for all black people, men and women, that you should measure vitamin D, and if it's deficient, to correct it, aside from the issue of fibroid, because correcting vitamin D deficiency is helpful in many other things. But most of the primary care doctors don't do that. So for those who didn't raise your hands, please make sure you ask your healthcare provider to measure your serum vitamin D level. And I almost guarantee you will be deficient. And then, of course, then you should correct it. Then I want to be back to this, racism, discrimination. So this is actually what we published in the article, that racism, discrimination causing chronic stress can also contribute to this chronic inflammation in the wall of the uterus. And then if this chronic inflammation goes unchecked, now we're talking about young girls in their teen years and early 20s, having and living with chronic inflammation in the wall of the uterus, not knowing it. And because usually it's asymptomatic or have subtle symptoms, and we'll talk about that in a second. If this goes unchecked, then eventually there's some DNA damage, and this famous MED12 mutation I mentioned happens. Once you have the mutation in the wall of the uterus, then you're going to develop fibroids. So after we published this, I got so many comments. I've never had comments on a paper I published more than this one. And everybody, and I agree with them now after I studied this more, that racism and discrimination is not just another factor, it's really the unifying factor. When you think about it, racism, discrimination, and the economic gap is the reason why communities of color might live up in certain neighborhoods where there's more exposure to environmental pollution. Is also the reason why more than other communities of color don't have access to the anti-inflammatory diet that Samira mentioned, the green vegetables, the fresh fruits, and that contribute to both obesity and also to the altered microbiome. The gut microbiome is heavily dependent on what we eat. Also, this also contributes to vitamin D deficiency. Vitamin D is a fat-soluble vitamin, so once you're overweight or obese, then even more you will be more vitamin D deficient. So all of this is connected. So we actually kind of published an addendum to the article where we put racism as the unifying theme behind all of that. So I just wanted to emphasize that. So yeah, so I think we all should agree that prevention is better than cure. We all heard this, as children, and it's very true. Not only for the cost, but also for being effective and also being, more in line with a higher quality of life. And I'll show you what I mean by that. So what is prevention? The science of prevention, for those who went maybe some public health courses, this is kind of what they teach you in public health. There's 3 types of prevention. Tertiary prevention, which is really treatment. It's like when the disease is so advanced, this uterus is full of fibroids, and then the patient comes to seeking medical help, and then you help them. So that's basically treatment. That's what we all doctors do, and that's what the patient in the audience have done, and that's considered tertiary prevention. At this point, as you can see here, the definition: intervention when disease process have advanced beyond early stage. What's the goal there? The goal is to improve the quality of life and try to minimize the impact of the disease. But the patient has suffered so much already by the time they reach that stage. And even especially for fibroid, there's, as Samira mentioned, there's a lot of normalization. Women having heavy bleeding and then just told this is just part of being a black woman, just put up with it. Or they having pain and they say, oh, that's normal, part of being a woman, especially a black woman. Or they actually know they have something abnormal, but they think that the answer is only hysterectomy, and they don't want hysterectomy. So they say, I'm not going to go to the doctor because he or she will say, I have to take the uterus out. So this is kind of what we do at the moment, and that's not enough. We really need to do more. So how about the secondary prevention? That's when the disease is so early, okay? So this is very important when the disease is so early. So this uterus or this individual have just a couple of small fibroids. Maybe her bleeding is just becoming slightly heavier than usual, or the pain in period become more than usual, or her periods becoming a little irregular. We should intervene at that point. And so if we can intervene at this point, and I'm going to show you, there is some options we can do at this point. This is secondary prevention, to prevent the disease from getting that bad, to keep the disease under control so that it doesn't get worse. So what I would really encourage you, people in your family, daughters, if you have young daughters, or just please spread the word, and I know the Fibroid Foundation does that, and I really congratulate them on the work. If you have any changes in your period, any slight change, don't ignore it. Go to the doctor and insist on an ultrasound. Don't just go. I know many of the time nothing is done, and you leave by a prescription for birth control pills. Don't settle for that. Insist on an ultrasound, and if we can see fibroid, then there is stuff I'll show you in a second that you can do to prevent the disease from getting to this early stage to this stage. The other opportunity where you can do is after myomectomy. So what do we do in myomectomy? Myomectomy, as I'm sure you all know, myomectomy means we go remove the fibroids one by one, stitch the uterus back together, and then close the uterus, and that's it. So that's myomectomy. So we take the situation from this stage to this stage. That's what we do in myomectomy. We know those small fibroids will grow, and the new ones will appear. This is another opportunity for secondary prevention, and I'll tell you what, based on evidence, what should we do. Because what do we do now? Most of the surgeons, we do the myomectomy and we tell the patient, you're cured, go and enjoy life, and so on. But they come back, and if a couple of small ones left, they grow, especially again in young black women. So don't do that. There's stuff we can do when you get to this point that prevent them from going back to be like that. So that's secondary prevention. That's something we can do right now. And myself and anybody I could convince in our medical community has been doing this for years. Then the ultimate really is primary prevention, is if we can stop the disease before it even occurs. I told you there's a lot of inflammation. So this is a uterus in a young woman, most likely black woman, in her teens or early 20s. She doesn't know she has chronic inflammation. Can we find these women? Somehow, and I'll show you now what we are trying to do on that front, although this is still a little bit in the future. If we can find these women, then we can again intervene by simple things, nutritional changes, some natural products, supplementation, and prevent the disease even from happening in the first place. And I hope Sateria will invite me in a few years, and we'll have made a lot more progress on that front. So this person is okay because at least she's getting treatment, but she's not happy. This person is happier because she managed to get to her disease early and prevent it from getting worse. But this one is the happiest if we can find her and help her to prevent the disease from even developing in the first place. So tertiary prevention. Treatment, again, you heard from Sateria and Samira about their experience, and I'm sure you're here because you're very familiar with this. How do we treat fibroid now? Surgery, unfortunately, is still the mainstay. I say unfortunately, even though I'm a surgeon, because really, almost for every other disease, we leave surgery as the last resort. Any disease. We teach our medical students. I know there's some medical students in the audience. That's how we teach them. You try with simple things first, and only if that doesn't work, then you go to surgery. For this disease, because unfortunately there was not a lot of good options here, traditionally it has become like the dogma. Fibroid equals surgery, either in the form of hysterectomy, and I told you we do too many, myomectomies, and some other less common procedure. Other options I'm sure you're familiar with is uterine artery embolization, where the radiologists go and block the blood supply going into the fibroid. That's also a good option, at least less invasive than surgery, but still a procedure. And there's some other options, probably less common. But I'm really excited that there is a lot of new development in the medical side. Just a simple pill you can take in the comfort of your home, and it can decrease your bleeding and shrink your fibroid. These just became available in the last few years. So these are a really great option, and I have one slide on that in a second. But I just wanted to again emphasize we're doing too many hysterectomies, and the public, you, are saying that. This is New York Times saying gynecologists are doing too many hysterectomies. Maybe up to 40% of the hysterectomies they do is unnecessary, and they do it for money. This is the New York Times. This is the public not happy with this situation, and I'm ashamed of that as a surgeon. We really are doing too many hysterectomies, so we need to work on that. Also, hysterectomy is not without consequences. So this is a paper we published, Dr. Samira Rafaela and others in our team, but there are so many other work on this from the University of Michigan, from Mayo Clinic, and so on, showing that hysterectomy, yes, you're not going to have any menstrual bleeding after hysterectomy. That's true. But it actually have other consequences. Even if we leave your ovaries behind, this is saying we just removed the uterus, but we left the ovaries. So you're not in menopause yet. But still, when we looked at this group, long term, we find more heart disease, more hyperlipidemia, and more dementia, more hypertension, more diabetes. So there's some serious consequences to hysterectomy. And our work and others now showing that the uterus actually secretes some stuff. The uterus might actually be an endocrine organ, and maybe that's why if we remove it too early in women in their 30s and so on, that can actually affect some other organs in your body. So you should not take the decision of hysterectomy very lightly, and you should have that kind of meaningful communication with your healthcare provider when they just say, let's just do a hysterectomy. So these are the medical treatment options. It's a new group of drugs that you can take by mouth, and it will actually treat your fibroid. For the first time, for the last 30, 40 years, the FDA never approved any drugs for fibroid, but then in the last 2-3 years, they approved 2 drugs, if I can advance. So this drug, elagolix, was approved in January 2020, so about 3-4 years ago. Then the next one was the rolagolix. I'm struggling advancing the slide. Okay, here we go. Maybe I should point to you.
The USB is behind you, so that might also be part of it.
Okay. So this was approved about 2 years ago, rolagolix. Okay. And then this one, linzagolix, has been approved in Europe, actually, but not approved yet in the US. Hopefully, maybe next year. So at least in the US, we have 2 medical treatment options for fibroid now. So again, if you suffer from fibroid-related symptoms, and this doesn't come up in the discussion between you and your healthcare provider, please make sure you bring it in the discussion. And look at the Fibroid Foundation website, there's information there. Just be an advocate for yourself. I believe it was you, Sateria, who said that, the patient is the best advocate for herself. So know your options so that you can engage in a meaningful discussion with your doctors. And I'm hoping with time, fibroid will be a medical disease. This is not unprecedented. Gastric ulcer, stomach ulcer was a surgical disease 40, 50 years ago. When a patient had gastric ulcer, stomach ulcer, we would remove part of the stomach. We do gastrectomy. And now this is a medical disease. You can actually even take the medication over the counter, buy it on your own. You don't even need a prescription for it. I'm hoping there will be less hysterectomies and less surgery for fibroid because of these medical treatment options. So this is my space holder. Yeah, so this is the tertiary prevention or treatment, basically. How about secondary prevention? When somebody diagnosed with early disease or after myomectomy, is there something we can do to prevent the disease from going further? Yes, we do. Yes, we can. Here is the data on that. Okay. Yeah, so how are we going to do secondary prevention? Again, for the sake of time, I'm just going to highlight some of the things. So our team has published this paper a long time ago showing that a specific extract from green tea, the active ingredient in green tea is called epigalcatechine gallate. It's just a long name, but basically it's a green tea extract. We have shown 14 years ago that it is effective in slowing the growth and actually killing the fibroid cells. Since then, many, many papers appeared in the literature confirming this. The same thing about vitamin D. We published this paper. This was the first paper in 2011, again about 13 years ago, showing that vitamin D can actually kill fibroid cells and slow the growth of fibroid tumor in animal models and so on. And since then, hundreds of papers appeared confirming that. But again, still not common information. Samira said she didn't actually find that everybody knows that vitamin D deficiency is a risk factor for fibroid. So putting a lot of research, fast forward now 11, 12 years, and we did extensive work in animals and also in patients, in women with fibroid, ourselves and then other groups around the world. So we summarized all of this evidence in this paper about almost a year ago now, showing that using this combination, natural products without prescription, safe, inexpensive, it costs about $4 per month to take daily green tea and vitamin D. We did the calculation. So using this approach, you can actually slow the growth of fibroids if you are diagnosed early, or if you had myomectomy, you can prevent the fibroids from coming back. So this is kind of the summary of this approach. Women with early disease, if you're lucky enough to be diagnosed early, or if you did a myomectomy and now you have minimal disease. What do we do now? We just tell you, let's just do watchful observation and see what happens. What happens is very quickly, especially in black women, this becomes a very advanced disease. And then now you have limited option. Now you might have to use aggressive medical treatment with hormones and so on, or surgery. Well, please use this regimen. And again, the evidence is in that paper that I showed you. High level of vitamin D, 5,000 international units per day. Basically, you need to normalize your vitamin D level. The Endocrine Society recommendation for vitamin D level is your level should be 30 to 80. I try to keep most of my fibroid patients close to the high end, so like 50s, 60s, and so on. But at least you should be in the normal range. And you can do this by this dose. And also use the green tea extract, 800 milligrams per day on full stomach. If you do this regimen, the evidence suggests that your disease will be under control. It will not progress, or there's a very good chance that it will not progress to such an advanced disease. So this is secondary prevention. And this is something we can do right now, safely, inexpensive, and using natural product without a prescription. You don't need a prescription for any of that. So I'm going to end up then on, so this is again emphasizing what I just told you. It's just so important. I wanted to emphasize it. So now the best really would be primary prevention. That's kind of more challenging because we need to find these women before they even become symptomatic. So that's more challenging. I'm just going to show you some of the highlights that we have done on that, but we still have a lot of work to do on that front. So primary prevention, just to kind of bring it home, for most of us, it's like pap smear. I'm hoping all of you are doing regular pap smears and so on. Why do pap smear? To prevent cancer of the cervix. And why we do it on everybody, right? So that's called primary prevention. That's screening. When you screen everybody for an important disease, to avoid an important disease, and you try to find things that can lead to the disease early and then intervene so the disease never happens. So it's the same concept. Can we do this for fibroids? We've been trying, if you can see that date there, I've been trying to get funding for this for like 12, 13 years now, and I'll never give up, Candace.
No pressure, no pressure.
So, but we really still have a lot of work to do. So we have developed in our team 2 strategies for primary prevention. Of course, the ideal would be if we can develop a vaccine. We just started. We started scratching the surface, and I've been doing this with Dr. Nahed Ismail, my wife. She's an immunologist. But there's a lot of work to do because we really have nothing to build on. So we almost have to generate data on the immunology of fibroid first. Then we start to think about the vaccine. So this is unfortunately still maybe a few years in the future. But this is more around the corner. If we can find a biomarker we can measure in the urine of young women, okay, which can tell us that they have a lot of inflammation. I told you that the main issue here is that the wall of the uterus in women on their way to develop fibroid have a lot of inflammation. If we can find a marker for that, something simple we can measure in the urine of these young women, then we can intervene with the same regimen, with the high-dose vitamin D, green tea. You can use this daily and of course maybe using anti-inflammatory diet and some lifestyle changes, avoiding the environmental pollution, all of this. Then you can bring the inflammation in your uterus down, then you actually may never develop a fibroid. And I'd just like to use this opportunity really to thank all of you and all our patients who donated, their blood and their tissue for our research. It always, really impressed me, and I get a warm heart when patients ready for surgery and they're anxious about surgery, and we approach them if we can get their permission to collect some of their data and some of their tissue, and almost 100% say, of course, please do, to can help other women don't have to struggle the way I struggled and so on. So thank you for your help with our research and the research of all the fibroid scientists. So we've been doing that. We've been collecting tissue from the uterus that never developed fibroid. As Samira said, 80% of black women develop, but still some don't develop. So we have been collecting samples from those to see what's unique about those, why they didn't develop fibroid. So we call this MyoN. And of course, we also collect the wall of the uterus, the myometrium, from those who develop fibroid. And unfortunately, there's a lot of those. And then we start to compare those two in the lab using, kind of advanced molecular techniques and so on. So I'm just going to show you some of the highlights. If you collect the normal myometrium, the normal wall of the uterus, and the abnormal wall of the uterus that's on its way to develop fibroid, they look the same for the human eye, and even under the microscope. When you stain them and look at them, they look the same. However, when you do the right molecular studies, they are so different. And again, the bottom line is that wall of the uterus that is on its way to develop fibroid has a lot of inflammation and a lot of stiffness, a lot of this extracellular matrix I mentioned, the collagen and so on. They are very stiff, and that's why they end up developing the mutation. So we've been studying this extensively. And then others start to publish, confirming our data from our other groups, which is always good to see, to validate your data. And also we develop kind of small tissue model in the lab to help us study this. The bottom line, we think this is kind of a paper we just published last month, just summarize what I told you. Everybody starts with a normal wall of the uterus, normal myometrium, but then black women tends to have more inflammation already at that early point. And then if you're exposed to those other risk factors we talked about, environmental pollution, lack of vitamin D, then that's when you fast forward a lot of inflammation and you develop the fibroid. The same thing actually happened in white women, but the inflammation is much less. And that's why fibroids is much less common there. So can we do something to find these women? Yes, we are working on a urine test to find this. And this is just an example of some of the markers we found to be useful. A marker called TGF-beta1. It's just a marker, and you can measure in the urine. And it's very high in women with fibroid. But after we do myomectomy, for example, it almost disappears or goes down dramatically. And we also have some other markers. So it is promising. We're not there yet, but hopefully we'll get there soon, that we can find a marker in the urine of young women that tell us that they have a lot of inflammation in the wall of the uterus. And then we can then encourage them to use vitamin D and green tea to prevent the development of fibroid. That's the other marker I talked about. So we're hoping to develop this kind of test. Another way to find these women also is a special kind of ultrasound. It's called shear wave elastography, because I told you the inflamed uterus is stiffer. So when we look at it with a special kind of ultrasound, it's called SWE or shear wave elastography, we can see that they are actually stiffer than the normal myometrium, the normal wall of the uterus that would never develop fibroid. So we're working on these two different methods. And again, once we identify these women, we can give them vitamin D and green tea. And you can see here the inflammation. This is just a marker for inflammation. It's called TNF-alpha. The inflammation goes down dramatically to the normal range. And then we hope then they will never develop fibroid. So this is kind of the model we're working on to find these women before they develop fibroid, but they have the inflammation, intervene with these simple natural products, inexpensive and safe products. And we actually got NIH funding to study the safety of green tea in young women in the last 2-3 years, and again proven that it's perfectly safe at this dose in young females. So we know this approach is safe. And then hopefully we can prevent the development of fibroid. We published this in a recent article, and this is actually the dream in our group. We talk about fibroid-free world. So this is the goal we are aspiring for. So this is my last slide. This is our amazing team at the University of Chicago, our collaborators, and of course we always acknowledge funding from Candace and her team at the NIH. Thank you so much.
I took some notes. One thing I did want to just clarify is that phthalates are plastics. So if you're drinking out of plastic water bottles, or yeah, we usually have. Yeah, I know. We usually when we don't cater, we bring cardboard water or the metal ones, but just think about all the places that plastics touch your body. So that was amazing. Thank you for that research. Are there any questions?
Definitely.
Yes. Please.
I've just been diagnosed with BME and having a vitamin B deficiency. But when I got the ultrasound done, as a matter of fact, I got like 2 done, and it always comes back normal. And then my pap smears always come back normal. So I'm a little confused on, I have a lot of symptoms. I'm always tired. So I know for sure that's a symptom of the vitamin D deficiency. It's a lot of symptoms for the uterine fibroids. Obesity. I'm obese, and so I'm confused on. I know for sure I have uterine fibroids, but they haven't detected it yet. So is there another test besides the ultrasound that?
Right. Well, thanks for sharing that information, and sorry about your hardship. So you have the symptoms. Can you hear me? Do I need to? Okay. All right. I thought this was. Yeah. So you're definitely describing the typical symptoms of fibroid: the heavy bleeding, the anemia. And they did the kind of ultrasound where they put the probe in the vagina, like transplant, and still told you there is no fibroids.
Nope. And every time I get my pap smear, it's normal.
Right. The pap smear is a separate issue. I mean, I'm glad you're doing it regularly, but it has nothing to do with the fibroid. So I just mentioned it as an example of primary prevention. So this is surprising because honestly, fibroid typically, if they are 0.5 centimeter or more, the cutoff for ultrasound that they cannot see fibroid, if it's less than 0.5 centimeter, basically 5 millimeter, which is really tiny. So unless you have many of those, like tiny, very tiny fibroids, but maybe many of them to cause this kind of severe anemia, I don't have a good explanation. Now, MRI is another option. This is more involved imaging. So we always use ultrasound. It's very simple, available, quick. But many times, especially women going to surgery, we like to do MRI. MRI is more sensitive than ultrasound. So I would definitely ask my healthcare provider to do an MRI. This is just like a more advanced X-ray, more accurate than ultrasound. And yeah.
Can I tell you one other thing? It also said on the report that there was no sign of endometriosis. And it said the only thing they found was like a little thickening.
A little what, sorry?
Thickening.
Okay, of the lining of the uterus, of the endometrium.
Just a little thickening, but I mean, it was like a mild.
Right, and that shouldn't explain. May I ask?
They said they won't let me. They won't let me do an MRI because the ultrasound came back normal. If it came back abnormal, if they found something.
But you have the symptoms. I mean, definitely you have a good case. May I ask if you are premenopausal or you're not postmenopausal yet?
No.
Yeah, right. Then definitely I would say MRI is indicated. I mean, they should order it. I mean, it's very common. And the justification would be actually that you have the symptoms, because at the moment we don't have a good explanation for your symptoms. So I don't see, for example, insurance declining it or anything like that. But that would be the next logic step.
Yeah.
Okay.
And I'll add to that, I'm glad to see all the hands. I'll add to that we always want to make sure we have the best care provider possible. So if there's ever an instance where you have questions and you're still not feeling well and your provider's not meeting your expectations, please get a second opinion. And please, we're going to launch a physician's referral at the beginning of the year, but it's so important to research your provider, make sure that they specialize in the areas that, if you know your diagnosis, but definitely they should work with you. Like when you go, there's a term that we use called shared decision making, which is where you list your priorities for care, whether it's any symptom that you're having, and then your provider will apply their expertise to help you to accomplish your goal in meeting the goals that you have to feel better. So at bare minimum, you should be getting what you need. And I know it's frustrating because I went through the same thing. But just, try to do what you can. And if you email us, we'd be happy to refer you to some local providers who are excellent.
Okay, can I have a card?
Sure. After, yeah.
Oh, I'm sorry.
Okay. I'll start with this lady right here with the scarf on. Yeah.
Thank you. Hello, everyone. So my name is Dr. Tanika Jones. I'm a tissue engineer studying fibroid research at Lehigh University, but I'm from Chicago, and I have the lived experience. I actually have my made to be performed by one of your colleagues, Monica Christmas, as in Chicago.
Of course, yeah.
Which was an impetus for me doing this work, actually. So my question, I have two. One a comment as a person who's on both sides of the spectrum now. Dr. Al-Hendy, could you share some insight into helping patients and potential patients know what are the buzzwords to advocate? We talked about vitamin D. My primary is at Northwestern, and she still is. When I asked for the vitamin D test, she indicated she needed something to order it. She said, I can't just order a test because you think you need a vitamin D test. She did, because it's about, being a patient advocate and understanding, and she's been a great partner. She has. However, I did end up at University of Chicago for my myomectomy care. But I wondered, if I didn't have the background that I have and the knowledge that I have, how can we help other people who are more laymen understand what are the terms you need to say? It wasn't until I couldn't do my yoga correctly, and I kept pushing for the ultrasound. And in Chicago, as you know, it's not as easy as get an ultrasound. You're on a waiting list for months, particularly in Chicago. And so can you talk about, one, what are the buzzwords that these patients need to say to their physician to say, hey, I really need this test? But two, what are some workarounds to already knowing that diagnostic test that you need that's so critical could be months away?
Yeah, these are real life challenges, and again, back to the election, hopefully we get the right, administration that cares about health and
Yeah. I can't wait for Dr. Candace.
So, but aside from the access and the waiting for months, because really I don't have a magic, wand to change that. But ultrasound, I mean, I agree with Sateria, maybe changing providers, maybe some, healthcare plans, healthcare establishment have easier access. I mean, at the University of Chicago, and I hope you had a good experience with us, really the turnaround for ultrasound is very quick. And again, your provider can be your advocate, because we don't do the formal ultrasound. So we order it, but then it's done by typically radiology or somebody else in the OBGYN department. So if there's any delay and no good reason for the delay, then message. I mean, I hope all of you are using now my charts and messaging your doctors and healthcare provider. I get, like, even now after I'm done, I'm going to check my messages. I get daily messages. If there's unnecessary delay for your ultrasound or any other test, get your provider to be your advocate. I mean, I've talked to my ultrasound unit many times, like, why is this? This is important, and so on. So this can also be a way. About the vitamin D, you really don't need a reason. We talked about black women being at higher risk, so that's the downside. The good side is just being black is a reason to test your vitamin D. The endocrine society say these groups, and they make a list of the groups, that they should have regular vitamin D checking because they are at higher risk of vitamin D deficiency. That risk factors including being black. So let's at least take advantage of that. So you're never going to be denied. I mean, I hear from other providers, it's expensive and it will be denied. I've never seen it denied, even aside from the fibroid issue. So just engage your healthcare provider. Sometime, like, don't take no for an answer. And again, as Sateria said, if you feel you're not getting the care that you deserve, consider. I see a lot of patients in second, third, even fourth opinion. So just seek help elsewhere. But there shouldn't be, you don't need a good indication or reason for vitamin D. So that, and also finally, I would say, be your advocate. I mean, I love when the patient comes with, on their phone, they have read a lot of material and seen YouTube videos, etc., and say, what do you think about this, or what is that? And then we can say, oh yeah, there's evidence for that. This one, honestly, I have no evidence for that. It's up to you, but I cannot recommend or not recommend. But know your options. That will elicit better attention and better interaction with your healthcare providers.
We're talking about vitamin D. We take vitamin D3. It to be daily, or how often is more efficient?
A great point. D2 or D3 are fine. It's just they come from different sources. One is plant and one is animal source, but at the end it's the same active ingredient. So D2 or D3 is fine. Now the amount, so I kind of simplify things here to bring the message across. If you are very deficient, I have seen black women with fibroid with no vitamin D, like vitamin D of 1. The normal level should be 30 or higher, as I showed you. So they literally have no vitamin D. So taking the daily supplement I mentioned is not going to correct it. So we have to give them very high dose. I use again the Endocrine Society, which is 1 tablet once a week. It's 50,000 units. For that you need a prescription, okay? So I do this for 3 months and then test it again. Most likely if they are so deficient that wouldn't be enough, so another 3 months. Then once we bring them to the normal range, then we do the maintenance phase with that, with the 5,000 international units per day. So the answer is, again, work with your provider, because if you need the very high dose vitamin D, that you need a prescription for that. The real guide here is your level. So keep measuring your level until we can reach level around 50, 60, or as close to 80 as possible.
Thank you.
I have a question. I had recently gone for a consultation for a hysterectomy. I had open myomectomy back in 2017, removing 40 fibroids. They left 2 behind. I now have 25. They said that I was not a candidate again for a myomectomy because they're worried about bleeding and also scarring. Are there any other options that I can do besides the hysterectomy?
Absolutely, absolutely. So we talked about the medical treatment, okay? May I ask, are you planning to have more children or not? Or okay, so so that even opened the options even more. So there's medical treatment options. I mentioned the 2 that approved in the United States by the FDA, urologolics and elagolics. So I would definitely bring this up with my doctor. And I'm surprised that didn't come up. I mean, these options are FDA approved. They should be among the different options that we discuss as doctors, we discuss with the patient. So that's that. Another option, if you're not planning to have more children, is the embolization. Is that procedure where the radiologists go and cut the blood supply to the fibroids. That also could be a very simple outpatient. You go in and out very quickly, and the results are very good. So there are definitely several other options. I understand why they're not offering myomectomy, because every time we do surgery, like I tell my patient, the easiest surgery and the safest surgery is the first one. Every time we go back in, there's more scar tissue, things like that. So I understand why they are maybe reluctant to do another myomectomy, but you might not need surgery at all. And the good news, and I kind of didn't mention that, is the fibroid issue tends to go away at menopause. I know a lot of women don't like to hear the word menopause, but in case of fibroid, that's actually a good word, because then your estrogen level goes down. Fibroids feed on estrogen. And when your estrogen level goes down, the fibroids should naturally start to go away and melt away. So this could be a really good way to bridge you into menopause. And I'm not going to ask how old are you. I never ask a woman how old she is. But this could be a very nice non-surgical bridge into menopause. Then this issue would be behind you.
I just want to say one more thing. They also said that my uterus, they could feel it in my stomach. Is that possible?
Yes, I mean, when the uterus gets very large, I mean, you might remember the picture I've shown you, that unfortunate situation, the uterus was all the way to the diaphragm, she actually was not breathing well because the uterus is all the way up here. Yes, when the uterus gets big, definitely it can be felt in the abdomen, in the stomach. Yeah.
I'm glad you asked that question, because we often hear from our community that they've gotten feedback that a doctor can't remove one fibroid without doing a hysterectomy. And then on the opposite end of that spectrum, we have Dr. Al-Hendy, who removed 80, other providers who removed 50, 60. So again, please see a provider or reach out to us to get referred to one that's really going to care for you and has the skill level. Because oftentimes what you're being offered is per the skill level of that provider. I was going to also recommend embolization if you're not interested or looking to have children, because an embolization does preclude you. It blocks blood supply to the uterus. That's the 4th surgery that I had. I was 44 at the time, and I will say this: my uterus was about a 16-week size, and while I had the embolization done here at Georgetown by one of the top radiologists in the world, I had a lot of pain afterward because my uterus was the size that it was. So while embolization is advertised often as, you know, you can go in, out the same day, it varies per person. There's nothing that I would change, but I just would like to set a realistic expectation for what you will experience if you have if you have an embolization, because everyone is different. I was pleased. It did send me into menopause earlier. And Dr. Al-Hendy mentioned a bridge to menopause. I think it's important to have that conversation as well, because the medical therapies that Dr. Al-Hendy mentioned that aren't really widely publicized can be very, very useful for getting through those heavy menstrual bleeding episodes when you start perimenopause, as a bridge to menopause so that you can keep your uterus. And I use that. I use tranexamic acid, which was phenomenal because I only took it during my period, and it helped me clot, and I didn't hemorrhage as much, and it, you know, it's why I still have my uterus. So just, you know, just utilize us as a resource to get the information that you need. Menopause is a whole additional conversation that we now do a lot of education and work in, because for me, menopausal symptoms were about that much less of a headache than fibroids, because you get hit with so many different, some women, not all, get hit with so many different symptoms. I also want to say, and we can take maybe one more question and then need to move on, but I also want to highlight that the Fibroid Foundation supports communities in 181 countries. And so that tells you that uterine fibroids are not just specific to women of African descent. They cross the whole entire gamut, that we realistically now don't have the research to really identify the impact on all ethnicities that are treated. I'm sure you see within your treatment community, your patients, many ethnicities.
Absolutely.
Yeah,
Absolutely.
seeking treatment for fibroids. So I just want to share that with all of you, and through our upcoming study, we're looking to speak with women of all backgrounds, all walks of life, to learn how fibroids have really impacted them. I hope that's helpful. I'll take the lady up here in the black sweater.
Hi, thank you so much for your presentation.
Welcome.
The wealth of knowledge that you really shared with us. For me, my grandma had fibroids, my mom has fibroids. I'm not going to speak that over myself, you know, but I do want to educate myself and kind of be aware of like how I can better prevent my chances. I did want to ask a little bit about the oral GnRH receptor, and just like maybe like, could you speak to like the side effects, maybe like the long-term effects of taking the medication? Because I remember researching it for my mom, and like what came up was like the increased risk of like osteoporosis and like bone density loss. And I mean, I want to be an advocate, you know, for that, but there's so many nuances, and I trust you from just hearing you speak.
Thank
so
you.
Thank you.
Right. No, that's fantastic, and you know, your mom is so lucky that you are trying to help her and so on. So I'm gonna answer that. Of course, it's a very important question, but I'm gonna quickly take that opportunity, because I mentioned earlier that fibroids tend to run in families. That doesn't always mean there's genetic stuff. Like that you cannot do anything about. It just runs in my families. Most likely, because actually the mutation that I mentioned, this MIT12, this DNA change, the MIT12, it's actually just in the fibroid. It's not in the blood. Like, you know, if even your mom or your grandma, if we take a peripheral blood and look for the mutation, it's not there. It's just in the fibroid itself. So it's not a genetic disease. It's not like cystic fibrosis or sickle cell disease and so on. So I just wanted to emphasize that. Many people think it runs in families because families tend to live in the same kind of environment, eat similar food, and so on. It's just no same environment, but not necessarily genetics. I just want to emphasize that, so that, for example, in your case, And I hope you don't have fibroid, and I hope you never get fibroid. But certainly you have high risk because of the family history, but it doesn't always mean genetics. And then just another quick question, because I'm so eager and so believing in this prevention approach. So yes, we're still trying to find that marker, and for example, you would be a great candidate because we're looking for young black women who don't have fibroid. So we exclude those because we want to diagnose fibroid before it develops. But they have very strong family history, and we've been collecting samples and so on. But to be honest, because the intervention is just so simple and safe and expensive, vitamin D and green tea, I would actually encourage you, because you have the family history, and you are, at least the appearance to me, that you are African American or black, so you have higher risk. So I would encourage you at least to know your vitamin D level and normalize that if you are deficient. And I would encourage also you to use the green tea as a preventive approach. So now to the treatment, yes. So these treatments are approved in the US for 2 years, okay? The same clinical studies have been seen in Europe by the equivalent to the FDA in Europe. It's called EMA, European Medical Association, and approve this medication indefinitely because they are really safe long term. The FDA, in their wisdom, they felt because of the bone issue, because they were worried about weakness in the bone, the osteoporosis, will limit it to 2 years. So what I've been doing to my patient, because I know the data and it was safe, and again, in Europe it's approved indefinitely. So I do a scan for the bone, for those who want to go beyond the 2 years. It's called DEXA scan. It's just a simple bone scan to make sure the bones are healthy. And if it is, and so far I have seen all my patients who have used this for 2 years, they have normal DEXA scan, then they can continue. I also encourage all my patients on this medication to use calcium daily to again help their bones. 1,000 milligrams of calcium carbonate every day. With that, they actually can continue for a long time. The side effect profile is minimal. It's really, many patients tell me, I feel like I'm not using anything, but they have no bleeding and less pain and so on. So minimal side effects.
That's phenomenal.
On that genetic, I'm glad that you clarify that that's not genetic.
No.
Because my 2 daughters, they have.
Yeah.
And they blame me. They got passed the bad DNA to them.
No, it's not genetics.
So Dr. Al-Hendy, that's hilarious. That's a phenomenal recommendation to do the DEXA scan, because we keep getting feedback about the 2-year limit for the medical therapies. And so if you do the DEXA scan, then you'll know for sure whether or not, the bone has been impacted by the therapy. So thank you for that. You're always just so much amazing information. Please give Dr. Al-Hendy a round of applause. We recently launched a new 5-year National Institutes of Health research study. We're super excited about it. It's called Co-Equal, and it's a specialized center for research on health disparities in uterine fibroids. And our center with the Fibroid Foundation is under the leadership of Dr. Elizabeth Stewart at Mayo Clinic. And it will bring together various high-quality projects across different fields, including basic science, clinical research, translational studies, behavioral science, and social science. And we are honored at the Fibroid Foundation to be the co-principal investigator along with Mayo Clinic, the University of Florida, and the University of Mississippi on this study. The goal is to tackle health disparities, especially those affecting racial and ethnic groups related to uterine fibroids. Michigan, under the leadership of Dr. Erica Marsh, will lead the other center focused on this effort. And this is a big deal for those of you who may not be in the clinical community. For a nonprofit to be the co-principal investigator for a major NIH study and to partner with Mayo Clinic is just mind-blowing, and it's just really just such an honor to be able to interface with you and hopefully deliver some phenomenal feedback for the advancement of fibroid care. Thank you. Thank you. So whom might you think we have to thank for this thoughtful research study? The answer to that question is Dr. Candace Tingen, our next speaker. Dr. Tingen is with the Eunice Kennedy Shriver National Institute of Child Health and was named Chief of the Gynecologic Health and Disease Branch in February. That slipped by me until a few months ago. Yeah, so congratulations. She previously served as Deputy Chief since September 2023 and joined the Gynecologic Health Branch in 2015 as the Program Director of the branch's uterine fibroids research portfolio. She now directs portfolios in endometriosis, adenomyosis, which someone mentioned, a few of you, about the thickening of the lining. That's called adenomyosis, which is very common, uterine fibroids, and menstrual health. She also directs the Centers to Advance Research in Endometriosis, specialized centers for research on health disparities in uterine leiomyoma, and the 2 NICHD sites for the Human Biomolecular Atlas program. Through her work, she hopes to normalize conversations about gynecologic health, menstruation, and the phenomenal potential of menstrual blood as a diagnostic tool for women's health. Please join me in welcoming Dr. Candace Tingen.
So I, as Sateria said, am the branch chief of the Gynecologic Health and Disease Branch at the Eunice Kennedy Shriver National Institute of Child Health and Human Development. That is a big, long title, and it sounds scary and official. And so the whole reason I'm here today is for you to be able to put a name and a face with NIH. So that when you think of NIH, you can think of Candace, just Candace, thinking about you and wanting to do research and help research for you. So the NIH overall is can be really scary. We like to use acronyms. We like to put out press releases that have medical terms and that use government language and things like that. And so I think I just want to personalize what we do. The NIH is the National Institutes of Health, and if you hear that, you might hear that it's actually plural. So we're not one giant monolith. We're actually made up of a lot of smaller centers and institutes. And what the NIH is the American government's way of giving back to you in our science and research. We are the largest biomedical research institution in the entire world. We set the global standards for how to do good science and how to impact our population with good science, like the studies that you've heard from Ayman today. And we do that entirely for the American population. Not for profit. We are not a pharma. We're not like big pharma. We are not making any profits from our discoveries. We are doing it entirely for the taxpayers who pay us to do that research. And so the National Institutes of Health are divided, as I said, actually into 27 different institutes. Some of them are very focused on certain diseases or certain body parts, like you might have heard of the National Cancer Institute or the National Eye Institute, and those focus exactly where you think they might. Some institutes focus more so on a population. So we have a National Institute of Minority Health and Health Disparities, which are focused on minority populations. My institute is the Child Health and Human Development. So we're focused on primarily four populations: children, those with disabilities, pregnant and lactating women, and reproductive health and reproductive aged people. So that's why within our institute we are looking at uterine fibroids as well as endometriosis, menstrual health irregularities, and other gynecological concerns. And the great part about being where we are for the work that we're doing is that we've heard that there are adolescent antecedents for these diseases, that these diseases start in adolescence. So that means that our pediatricians, our experts in that area can go from, knowing the health of adolescent populations and child health populations, and then we can follow some of those cohorts as they grow and they begin to experience some of these diseases. So I just wanted to say, what we're looking at in terms of NIH, or we usually divide our institutes in half. So part of our institute does research on site. The bigger part of our institute, though, is where I am, which is what we call extramural. And my entire job is to find the best science in America and across the world and be able to fund that research to outside investigators, to folks at the University of Chicago and UCLA and small business awards that are developing new techniques for imaging fibroids, et cetera. So that's my job within my branch. And so what as we have looked over the last decade, I've been in the branch now for about 9 or 10 years, and so as the fibroid portfolio grew, we wondered, where do we need to go from here? So we're funding incredibly good science already. We fund Dr. Al-Hendy's investigations on vitamin D and EGC. That's the right one. Okay. And green tea are being funded through our institute, but we still wanted to do more. And we thought, where do we really have some strong questions? And one of the biggest questions is, why is there the health disparity that we see? We just heard it's not genetic. There have been very large studies looking at genetic differences, and there's nothing that tells us, oh, it's this gene that makes Black women or women with African ancestry more likely to have fibroids. So what is it? And so in thinking about that, I proposed centers for looking at specifically at the health disparities. And what we've done in the past, problematically and really across NIH, is that we had assumed if we include Black women in our studies, we'll be able to look at the health disparities. And it turns out that just including people in studies doesn't actually look at the differences in the way that you want to. You have to be targeting your questions to looking at the disparities. And so that's what the centers are really designed to do. And so I'm really, really proud to say that we were able to, it's a $15 million investment into these two centers, $7.5 million each over 5 years, into looking specifically at why there are the health disparities in uterine fibroids for Black women. And we are looking at some of the things that Dr. Al-Hendy talked about. Is it this systemic racism? Is it systemic differences in the way that clinicians treat patients? I find it, while it's accurate, I find it really hurtful to have to say over and over again to be your own advocate. You shouldn't have to be your own advocate. There is an entire system that is built on having the knowledge to help you. You shouldn't have to bring the knowledge to us and to your clinicians. And so I think that's a problem that we're forced to be our own advocates in some of these things. And so I think, really looking at differences in when Black women go to the doctor, are they asked the same questions about their uterine health, about their gynecologic health? Are they offered the same options? I think we have heard today very clearly proof that they are not. You are offered a hysterectomy and nothing else. No, people have not even heard about some of these oral medicines that you could take for 2 years that could help your symptoms. So there are very, very clear, I think, disparities in the healthcare system from a clinician's point of view, but also from what patients know from their own education, what they feel, how they interact with the healthcare system. Our biomedical research institution has not historically been very fair or very kind to Black people and Black women. And so there is understandably a lack of trust in some of these things. And so you don't necessarily want to bring it up with your provider because you don't necessarily want their opinion on some of these things. You're going to, if you want to keep your uterus, for example. So I think I'm really, really excited to say that these centers are specifically designed to work on those questions. And then one thing when we were writing it up that we made mandatory, and it's very unusual for NIH, is that we actually did force our researchers and our institutions that are very used to doing this research to partner with advocacy organizations. Because we want to make sure that the people that are out there that are affected by the science and by this research are consulted from the very beginning. And I don't mean once we get results, oh, we'll give it to you. We'll hand out flyers at Black churches and we'll call ourselves, done. That's not what I intended. I intended for the population to be integrated from the very, very beginning in these questions. And so I'm so excited to say the Fibroid Foundation is partnering with one of our sites and the White Dress Project with another. And that means that from the very beginning, when these clinicians and these scientists are designing the studies and the questions they're going to ask and the samples they're going to take, that women in the community are part of those conversations and that you're giving feedback on how you want to, participate in this. How often could you visit a clinic? How much blood do you really want to be able to give if you're feeling anemic and tired, with blood loss already? So some of these questions are really key. So I think that is a place that we have those launched this year. So they are our very newest initiative in our fibroid portfolio. And so I'm really, really excited over the next 5 years to see where those go and how we can then, from the results of those differences, educate the medical community, the research community, and the patient community about how, where some of these disparities exist and how we can then therefore really try to tackle those subjects and really try to make it to where you do not have to advocate so hard for yourself or see your fourth clinician in order to hear that there are medications out there for fibroids. So that's the intention of the centers, and a little bit more about NIH and who we are and what we're here for. But again, my goal is just to show you all that NIH is people and people who want to help you. And if there are ever ideas, we are trying very much to get better at our educating the public in ways that are digestible and are meeting people where they are. We used to meet them at community meetings and things, and now we know that meeting people where they are means Instagram and Facebook Lives and TikToks. And so that's where people are getting a lot of their gynecologic information. But it's also where gynecologic concerns are being talked about openly, honestly, without the fear. I get TikToks all the time because I'm interested in it now. That just in my reel, my reels on Instagram will be people talking about the clotting in their periods, and people talking about things that you would not have talked about publicly before. So it's really an amazing space. So I think between the research that we do, the findings that we're able to get out, the partnerships that we're making in the centers, and then the way that we are really trying to optimize the way that we're getting back to the community and educating the community, we're hoping to see some real progress in how women are treated fairly and really, at least you start to address some of the disparities in uterine fibroids.
That's amazing. Thank you so much.
Yes, let me turn to you.
Yeah, please do. So I speak very softly, so I do need the mic. I heard Dr. Tingen a few years ago explain what NIH does, and I was like, oh my goodness, we all need to hear that, because even though I interface with NIH, I didn't know how to explain it that way, and I think it makes it, and you're so approachable, so it's a game changer, I think. So thank you so much for that.
You're welcome.
Do you all have any questions for Dr. Tingen? Yes, ma'am.
Yeah, I'd like to know, and thank you very much for coming, you and Dr. Henry. Is there any study on fibroids and prolapse uteruses?
Yeah, so my branch actually does focus on pelvic floor disorders as well. So we have an entire pelvic floor disorders network, and that is made up of 19 different sites across the states that are looking at pelvic floor with prolapse and its intersection with our different gynecologic conditions, with fibroids, endometriosis, with pelvic pain, and some of the other symptomatology. So I don't know if specifically we are looking at that, but certainly there are women included in all of those studies, and perhaps a sub-analysis has been done. So I can look into that a little bit more. But certainly the Pelvic Floor Disorders Network includes many, many women with fibroids, because as we know, as we age, the chances of having fibroids is accelerating. And so the odds are that most or many of the women in our studies do have fibroids.
That's a great question too, because there are a lot of providers now who are incorporating pelvic floor therapy into their practices as well. So that's something that you might want to inquire about.
I just think it's important to point out, we talk to women with endometriosis about endometriosis, and we talk to women with fibroids about fibroids, but these things happen together all the time. A lot of these things are interacting, and so they are not separate in the way that we research things and the way that people conceptualize our research. is understanding that some of these are inflammatory conditions overall. They're reflecting an overall inflammatory environment, or they're reflecting an overall, hormonal imbalance, or they're reflecting some of these things. And so there really is overlap with a lot of these conditions as well, which we recognize.
Yes, up here.
Hello, thank you again for the information. Along with that overlapping, do you all have any research in regards to fibroids and the lack of being able to be pregnant or miscarriage?
Yes, yeah. So Ayman could have talked a little bit about one of his projects. So we actually do have projects that look at some of these fibroid-associated infertility. So the interesting thing about the infertility world is that despite a fibroid theoretically being able to block the entire cavity of the uterus, they'll still say, oh, that's not the cause of the fertility, that's associated with infertility. So it's kind of an interesting concept of fibroids and fertility. But yes, we have an entire fertility branch that looks at the impact of fibroids, whether you do some of these other trials, so looking at some of the alagolics and then pregnancy after, or looking at myomectomy and then pregnancy. We also do have studies looking at myomectomy followed by cesarean section, for example. So as Dr. Al-Hendy talked about, the more that you do a surgery on the uterus, the more possible there are for outcomes that we don't want, uterine rupture and bleeding and things like that. And so we certainly do look at the possibility, the overlap of fibroids, infertility, but also fibroids, pregnancy, and delivery.
Thank you so much.
Yes.
Thank you.
And the fact that you're not able to find that when we do it says that we're failing at getting that out. So we need to do it better. We do, for the record, have a brand new uterine fibroids information sheet where we try to sum up about 15 of our most recent studies. And so I think that should be one of the top Google hits if you look for uterine fibroids and NIH. So that's updated kind of findings that we found in the last couple years.
We'll put that on our website.
Yes, I'll link
to that. I'm sure Nicole got that. Okay. Hi.
I'm actually glad that she segued into the conversation around uterine fibroids and fertility, because I have lived experiences that go back 20 years where I always had painful periods, but I did not know I had fibroids until I was pregnant, and I lost my first baby to the fibroids. I didn't have a lot, but I had really big ones on the top of my uterus, and as the baby grew, they pushed the baby out. Then everyone says you have fibroids. I did have a myomectomy, and I do, thank God, have a 15-year-old vibrant little girl now, well, teenager, so I'm dealing with that. But I had a question, like, for women who are struggling with fibroids, and I do remember the vitamin D test. I do remember the anti-inflammatory diet that I was following. I was in the best shape of my life. But for women who are struggling right now today with uterine fibroids, and they do have desires to become mothers, what would be that example that you would tell them now? Because I know we talked about if you weren't looking to become a mom, but what does it look like if you are?
Yeah, I give this to Dr. Al-Hendy. I'm a Ph.D., not an MD, so I do not give medical advice.
And Dr. Al-Hendy, would you also, if you have any recommendation on when you should freeze your eggs, because that's a mistake I made. I was hard-headed. My mom had kids late, and I thought I'd be in the same way, and they were calling me at 39 saying your AMH levels had dropped, and I thought that couldn't be, but it was.
So,
you want to come on up here? Yeah, here, you can. Come on.
No, I'm just stand, please.
Okay.
So as Candace said, I think now after 10 years, I didn't know it was already 10 years. You know so much, so I'm sure you can answer all of these questions. But to this point, exactly as Dr. Tingen mentioned, it's an association because I see a lot of women with fibroids, and they come because of infertility. I'm worried about my fertility. But then when you take the detailed history, they haven't even tried yet. Like they are not even with a partner. So I just wanted to clarify that. So it is an association, exactly as Dr. Tingen said. So the way I explain this to my patient, and that might be too simple for you guys, but I just want to say, so for example, like if we take 100 women with fibroid and 100 women without fibroid, and everything else is the same, matched for age and everything else, and everybody's trying to get pregnant, the 100 with fibroid, still a lot of them will get pregnant, probably around 50, 55 out of those 100. Without fibroid, yes, the number will be higher, maybe 70 up to 80. But it's not that if you have fibroid, you cannot get pregnant. So the recommendation, of course, if the fibroids are causing symptoms, and it's good to deal with the fibroid anyway, but I don't think women with fibroid should just label themselves as not able to get pregnant before actually trying. Now, if you have been trying for a year, like that's kind of the definition of infertility, that you're having regular intercourse for a year and still not able to get pregnant, then that's the definition of infertility. So that's practically a good way to test, because there's a very good chance that you will get pregnant anyway, and you still can carry the pregnancy to term and everything. But also from the insurance side, like if we start to do investigation for the infertility before that 1 year, then there's a chance that they will decline and that kind of thing. So now, as Candace mentioned, we are actually doing a study. It's called the FRIENDS study. Very nice name. If you just Google under my name, you'll find it. And it's actually back to the green tea. Because as I kind of mentioned, green tea is very safe, very simple, inexpensive, and it actually shrinks fibroid. And also by shrinking the fibroid and decrease the inflammation, it improves the quality of the lining of the uterus, the so-called endometrium, and that's where the baby implants. So it makes it actually better or healthier. So we're doing a study, it's ongoing, so I don't have data yet, but just to tell you that this is an important topic. We have women with fibroid and infertility, so they have been trying to get pregnant and not able to. We randomize them to green tea or placebo, which is a sugar pill, for 3 months, and then everybody then will get ovulation stimulation with a drug called Clomid, and also intrauterine insemination, which is kind of the standard treatment for women who are unable to get pregnant, the first line before IVF and test tube babies and so on. And then we're following them to see if adding the green tea actually will improve the pregnancy rate and the live birth rate. So this is ongoing. Again, please invite me again in a couple of years, and I'll show you the results. But yes, I mean, shrinking the fibroid before you try to get pregnant would be a good idea. You can shrink it medically. Now, these medications that we talked about, back to the questioner there, while you're using the medication, you cannot get pregnant because you're not going to ovulate. So while using elagolix or elagolix, you're not going to be able to get pregnant. But once you stop, the menses and the ovulation will come back within about 4 to 5 weeks. And then you can try to get pregnant. So we coined that term a few years ago, medical myomectomy. I know it seemed like a lot of you had a surgical myomectomy. Now I tell my patient, we're going to do medical myomectomy. They said, what are we talking about? So we use this medication to shrink the fibroid, okay, medically, without surgery. So if they're not in a hurry to get pregnant and so on, then we do this, 6 months, a year, and we monitor with ultrasound the shrinkage, and then when they are ready socially to get pregnant, then we stop the medication, and then they go ahead and get pregnant, and we have very, very good success rate with that.
Thank you. Thank you so much, Dr. Al-Hendy. This lady in the yellow,
thank you. My question is it Dr.
Tingen.
Tingen. Is there any research?
Candace is fine.
Okay. Is there any research that suggests women who suffer with adenomyosis may develop fibroids as later? I guess I'm over 45, so I have no issue with that. But I suffer with adenomyosis, but I've never had fibroids, but everybody else in my family has, which is, in my opinion, just as debilitating.
Yeah, Adenomyosis is incredibly, so for those that don't know, adenomyosis is somewhat related to endometriosis in that the endometrium and endometriosis implants outside of the uterus in places that it should not, and adenomyosis is when the endometrium starts to invade into the wall of the uterus. So your endometrium starts acting almost like a cancer, metastasizing into your uterus. So also not a good situation. And so I think there are some overlaps between that. I think we only have epidemiologic data on that just to say, oh, X percentage of overlap between adenomyosis and fibroids. We don't have a good causal link between those. And then I'll say the problem with adenomyosis is that it's incredibly difficult to diagnose, whereas fibroids usually, as Ayman said, can be seen on ultrasound, can be seen with MRIs. Adeno is much harder, and so usually adeno is only found, during surgery or even at post-hysterectomy by the pathologist will say that there was adeno. So it's a little more difficult to diagnose. So in that sense, our adeno portfolio is actually smaller, and I think it's harder to do research in that. But there is certainly some work ongoing. But if there is a causal link between the two, that they're somehow associated in that way, we don't know anything about that yet, unfortunately. Yeah.
Thank you. Thank you all. We have one last portion of our program today. And go ahead, Samira.
Yeah, I have one question also, maybe to both. What I learned about also is the diagnosis that for endometriosis, I think we had a presentation about it in the European Parliament a while ago, and I was shocked to learn that for endometriosis, I think it takes 7 to 12 years to get the diagnosis. For fibroids, 3 to 4 years in general. Mm-hmm. And when it comes to then disparities, do we see a difference there for Black women and white women? I think that is also one of the targeted solutions then, right? To prevent, well, in general, I think it's ridiculous that women need to wait so long for the endometriosis or diagnosis or the others.
Right.
But yeah, what can we do about that?
Yeah, so my branch very happily, again, we're very proud. We just launched the ACT-INDO study, which is a $4 million investment to research new non-invasive diagnostics for endometriosis. So right now, the only way to see endometriosis is to stick a camera in and actually see the lesions. And that depends on the skill of the clinician, just like Sateria said earlier. And so being able to look for biomarkers in menstrual blood or in the saliva or in the circulating blood would be really helpful there. I think a thing to remember when you're thinking about these diagnostic delays is that not everyone gets Ayman for their gynecologist, right? Most women, there are half of US counties don't have a practicing OB-GYN, which means a lot of women, and especially girls who are experiencing this problem for the first time, are being seen by pediatricians or by their GP or by people who had a few days worth of gynecological health in medical school, not people who specialize and focus on this. So what they know about, do they even know about these medical options? Do they really know how to see endometriosis or some of these things? It really does depend on the clinician that you see. And so I think some of that diagnosis delay is because of that. We don't have necessarily some of the tools that we need for endometriosis. I think we really do for fibroids. So I think in the fibroids world, we're more able to point to some of these disparities in offering those solutions and asking for those solutions, whereas endo, we have to acknowledge that it's harder to see and harder to visualize that condition. But yeah, I mean, I think, so that's what the centers that we've looked at to try to address the health disparities, as well as the new program in ACT-INDO, are ways that we are trying to give clinicians the tools and the understanding that they need to be able to offer every woman, no matter where she is, no matter what county hospital she goes to and what color her skin is, and what education she has about this problem, that they can offer a similar set of standard solutions and then have shared decision making with the patients where they are, what they're intending, and what they want for treatment of these options. Yeah.
And that, of course, is US-based. I have no idea why there's disparities globally. I'm still befuddled by that whole thing that women of color are just not given the same access, and it's a global issue. I have no idea. But I'm looking forward to us working together to try to overcome that, because it's just heartbreaking and it just shouldn't be. So thank you all for these wonderful, 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 Dr. Tingen, Dr. Al-Hendy, your comments are just, I took lots of notes, and I really appreciate you both. And we're going to cap off our program today by having Ashley, one of our wonderful volunteers who is joining us from the Detroit area, to give us the results of a survey that we did in preparation for Summit, assessing some of women's experience and perceptions related to their medical care. So please welcome Ashley Lee to the podium.
So I'm here to share the results of a recent questionnaire conducted by the Fibroid Foundation as part of our co-equal initiative focused on understanding and addressing the quality of life impacts faced by women with uterine fibroids. These results highlight both the physical and emotional challenges that women experience, pointing us toward areas where we can focus in order to enact meaningful change. So just a couple different categories. The demographic breakdown for the survey, it was 60% identifying as Black or African American, 20% as white, and 20% as other ethnicities. The impact of fibroids on life. So a significant 94% of respondents stated that fibroids have impacted their lives. This near universal response confirms that fibroids don't just affect our health, but touch every aspect of our daily life. Delays in diagnosis. So when asked about the time given to receive a diagnosis, 23% of respondents waited 5 years or more for a diagnosis, while many others reported waiting between 1 to 3 years. Delayed diagnosis is a challenge faced by many women, and our results underline the frustration, with 23% stating that they were very dissatisfied with how long it took to receive diagnosis, while 53% felt neutral about how long it took, and only 15% felt satisfied. Pain at work and impact on productivities. So fibroids don't just cause discomfort, they impact women's ability to work effectively. 46% of respondents reported experiencing pain at work more than 4 days per month, while 30% reported 1 to 3 days. Bleed-through incidents while at work. So in addition to pain, 77% of respondents reported bleed-through incidents at work. So not sure if anyone has experienced that personally, but this experience isn't just physically uncomfortable, it's emotionally challenging, embarrassing. It can affect your confidence and peace of mind while trying to earn a living. Social and emotional impacts. 84% of the respondents reported canceling plans due to unexpected symptoms, showing that fibroids can disrupt our social lives, relationships, and daily routines. And 95% also reported an impact on their emotional well-being. I know we talked about it, how fibroids can really impact your mental health. I know I've experienced that personally. Financial burden on menstrual care. 45% of respondents spending said that they spend between $20 to $50 each month on menstrual care products, and 24% said they spend around $10 to $20 each month. Menstrual product satisfaction. When asked about satisfaction with different menstrual products, 31% rated their products very good, while 15% felt their products were only fair or poor. So this suggests that many products on the market may not fully meet the needs of women with heavy flow, especially those with fibroids. Quality of medical advice, only 23% rated the advice as good, while 31% rated it as fair and 15% rated it as poor. Lack of professional medical advice. 62% of respondents had not received advice from a medical professional on managing a heavy flow. Age of symptom onset. So the ages at which symptoms began varied widely from adolescence to adulthood. Teenage years, 13 to 19, approximately 9%. 20s, approximately 21%. 30s, 42%. And 40s and above, 27%. So these findings make one thing clear. Fibroids impact women in profound and varied ways, from delays in diagnosis to the impact on work, social lives, and emotional health. It's evident that the journey with fibroids is a challenging one. The Co-Equal Research Center's goal is to address these disparities through a comprehensive approach that combines research, advocacy, and community support. Together, we are working towards a future where no woman has to face the challenges of fibroids alone. So that was the highlights from the survey that went out. I was also asked to just share my personal fibroid journey from a patient standpoint. So just wanted to share that with you guys. So my personal fibroid journey is one of hope, faith, and resilience. So in 2022, I got engaged in 2021. In 2022, I was planning my wedding. And I was working out diligently, trying to make sure I fit into my wedding dress. But I was losing weight, but my abdomen was still like protruding a little bit, and I didn't know what was going on. I just thought it was like me, or maybe I needed to like change something that I was eating. I didn't know. I was feeling bloated, having lower back pain. I just thought it was from working out. I didn't know, because I didn't know nothing about fibroids. So in August of 2022, I went to the doctor for my annual physical exam, and my doctor felt an unusual hardness in my lower abdomen. She asked if it hurt. It didn't hurt. She recommended me to have a transvaginal ultrasound, and at that moment, that's when I found out that I had fibroids. Now, like I said, at this time, I had never heard, well, I had heard the word fibroid, but I didn't know what it was. I had no real knowledge of what it was, how it could affect your quality of life and your fertility. So my primary care physician, she suggested that I seek out a GYN who could talk with me through the next steps on how to figure out a plan of action. So the ultrasound showed that in September 2022 that the largest fibroid was about the size of an orange. And so while I was talking to my GYN, I had expressed to her that I wanted to conceive. So she said, well, let's wait it out for a year and see if you get pregnant, and then we can go from there. But after hearing Dr. Al-Hendy, your presentation, I feel like this is where the secondary prevention should have come in. And it was nothing. It was just sitting me on my way. So I went back to just living life regular. Like, I didn't make any changes to my diet. I didn't add any vitamin D to my vitamins that I take every day, the green tea, nothing. So fast forward to a year later, fall of 2023, I hadn't conceived. I was back at the doctor for my annual physical. And over that year, I had noticed that the hardness in my abdomen had increased, like the size had increased. So I'm like, I think these fibroids have grown or something. Something just didn't seem right. And then over that year, my menstrual cycle went from 5 days to 7 days. The blood clots during my cycle were ridiculous. It was bad. So I had to advocate. I went into the exam and I said, hey, I need another ultrasound because something is not right. I know you guys think that I have fibroids, but I think they've gotten bigger because something is not right. So went, and as I suspected, they did increase in size. And it had increased so much that I felt like my back was against the wall because my only option at that time, due to the size and location, was an open myomectomy. I couldn't even have, or at least I wasn't offered, like a laparoscopic procedure or anything like that. It was an open myomectomy. So, it has to be an open myomectomy. And by February of this year, from when I had my first ultrasound in September of 2022, that fibroid had like doubled in size. And so when I was just so like focused on getting some relief from the pain. I wasn't even like processing how much of a major surgery the open myomectomy was until my mom was like, wait a minute, like we need to go get a second opinion. That's why it's important to not only advocate for yourself, but to have people in your corner who's gonna advocate for you also. So when I got a second opinion, and that's when that GYN, she was like, well, let's do an MRI so that we can see a better view of things. Once again, they didn't tell me to get an MRI before. So got the MRI, and both the doctor who I got the second opinion from and the doctor who ended up doing my surgery was both like, yes, like we need to do this surgery like sooner than later, especially like if you want to have kids, because the fibroid had grown so big that it was distorting my uterus. And they were saying that if I waited longer, that it could possibly have resulted in a hysterectomy. So I went from just feeling like I just needed some relief to like feeling like just literally having to make like one of the biggest medical decisions of my life. So I scheduled my open myomectomy. I had that in May of this year. And I had never really felt like my mental health was so just shocked because I had never really felt like my health was at such a just a bad place, because they were saying like because of the size of the fibroid that it could push up against other organs. So it was a lot, y'all. It was a lot. And ended up having the surgery. The surgery went excellent. It was minimum bleeding, my surgery. My doctor literally said, if you could have planned out the most perfect surgery, this would have been it.
Wow.
And what they had thought was multiple fibroids ended up being one large fibroid. It was like the size of a cantaloupe. It was huge. And they said that my uterus at the time was like a 20-week pregnancy, or maybe like 5 to 6 months. And just to, it just gives me so much more appreciation for my body, because just to know that I was dealing with all of that and still doing the day-to-day activities, working out, everything with that thing just trying to take over. So during that process though, I felt very alone, because nobody that in my inner circle knew about fibroids, or if they did, their response would be, aren't those normal? Don't all women have those? Like, no, it's not normal. There's nothing normal about it. And that's when I found the Fibroid Foundation. And because I just needed to find a community that understood exactly what I was experiencing. And so that's my story. And I just really appreciate all of the information that we received. Definitely since the surgery, my cycles have been night and day. Literally, like, I was like, wow, this is crazy that you could really think that something is so normal that's not normal. And then you see the other side of it. It's crazy. But I've added vitamin D to my daily vitamins. Going to get some green tea extracts ASAP because I don't want them to come back. And just like little stuff that, like I said, the lower back pain. I was even having like pain in my leg. And all of that was related to that fibroid. And I don't have that pain anymore. And so I just hope on today we all leave feeling empowered, encouraged, and more hopeful about the continuous research. And I know everyone's journey, fibroid journey is different. You may not be going through it personally, but you may know somebody that is. And I just pray we all have the resilience and faith needed to overcome the obstacles that we face, like the different health challenges and the whole fertility aspect of it. Because it's a lot. So, that's it.
Wow. That was amazing. Thank you so much.
Thank you.
Thank you. I don't feel like I really have to say anything after that. Thank you, Ashley.
No problem.
Thank you all for being here today. Thank you for our guest speakers who traveled in. Please know that we're a resource here for you if you need us. And we look forward to interfacing with you. There are 26 Fibroid Foundation chapters across the United States. And if you'd like to start one or join one, please reach out to us. I'd like to thank our sponsor, P&G Always, for being here. And please let us know how we can help. Thank you and have a beautiful rest of your day.